So we're going to talk about imaging and physiology in focus. But before I talk about the section, I'd like to give you a brief introduction about that. So recent international and national guidelines have upgraded intravascular imaging and physiology to the highest level of recommendation. And I'm not going to go into the details about these. You are all familiar with the recent guideline changes. But this doesn't reflect the reality we face in the cath lab. So the adoption of imaging and physiology is very low, as you all know. And these are just data coming from the New York registry, data coming from the VA on physiology. The adoption is really not following what the recommendations are. And the problem is multifactorial. We can discuss about all of them. Operators' preference, they really don't trust imaging. They rely on their own expertise and their ocular stenotic reflex. There was insufficient recommendation in the guidelines before. There are, of course, costs related to the procedure, reimbursement issues. In sites that don't adopt an imaging and physiology program, there are procedural constraints and problems related to procedural times in the cath lab that disrupt cath lab workflow. There's a lot of local variability, so you might find physicians that are really into imaging and physiology. Some others in the group really don't care about, and there is great heterogeneity among the health system in general and how people use those tools. But most importantly, it requires specialized expertise and training. And those are the 2 points that I would like to highlight next. So this is a publication from 2020 on that highlights a survey conducted at the CRF annual fellows course. And they asked fellows to report their perceived competency or how much training they perceive they received during training for physiology and imaging. So you see that most of them reported having been exposed to expert or sufficient training, but when challenged with very basic competencies to do physiology, like 4 basic requirements and 8 requirements for intravascular imaging. The first 4 related to using imaging to plan your procedure, and the latest 4 for competencies related to checking your PCI result with imaging and making sure that you have an optimized result and you don't need to do anything else. So those fellows pretty much failed on the competencies. So over 50% are fully independent to do a proper physiology work, but imaging is really lagging behind. Less than 20% of them are fully independent for the basic steps on using imaging to guide an intervention. This is not a fellow problem. This is also reflected on, with senior operators in the expert sites. And this is data from 2 landmark studies with intravascular ultrasound. You are all familiar with the IVUS XPL and Ultimate trials. And this pooled analysis looks into patients that met IVUS optimized criteria versus not. And you see that just opening a catheter and imaging a vessel and really don't interpreting images and reacting to findings will not change outcomes. And this is significant. Same thing happens with physiology. Physiology is very easy to interpret. It's a number. We all understand what that number means. But there's a lot of technique involved on interpreting the findings, calibrating, making sure that you have no drift, and so on. So this is, again, a CRF data published in 2017 of more than 4,900 pressure traces conducted in the confines of the contrast study. And if you look at these data coming from expert sites on physiology, providing a huge data set of imaging, almost 20% of them don't check for drift. So any physiology number you get cannot be validated, right? So if you don't check for drift, you don't know if your results are valid. And in the 80% of cases that they checked for drift, almost 20% had significant drift that was not perceived by the operator. And we're talking about expert sites participating in a clinical trial. So these 2 together represents more than 30%. So over a third of the patients have physiology data that cannot be interpreted, but are still being used for clinical decision making. So there is a lot of learning to be done in the physiology world as well. And the assessment of microcirculation is growing and growing. We're seeing more and more papers on INOCA, on NOCA, and all the other applications you can do with microcirculation assessment. And beyond learning how, about the mechanisms that regulate coronary flow and learning all the new names of the new indices of microcirculation resistance, we need to go back to the basics and really pay attention to the technique. And these are cases that we get in the core lab from expert sites with really suboptimal quality. Looking just at the numbers is not enough. So these kind of shape the vision for this section, which is called Imaging and Physiology in Focus. And that was one proposal that we made to Alexander to incorporate this section into JSCAI as a source of training and learning. So this is not a case report. We're going to use case vignettes to illustrate interpretation and application of invasive imaging and physiology. So this will be a section for learning together. We're not looking for the most complex CTO retrograde cases where you did an IVUS. It can be any imaging case that have a very clear teaching point on interpreted imaging or how you used imaging to guide your management. So I'm very happy to have Ziad and Natalia as co-editors of this section with me. And these are the requirements. So we're accepting up to 1,000 words, up to 2 figures, and we stimulate people to create multi-panel figures, and submission of color figures are going to be accepted at no cost. We're also highly recommending authors to submit the online videos. So we want to have the full run, or whenever applicable, right? We're introducing a focus point section inside the paper where we're going to highlight the key teaching points, so really try to summarize the key findings and how they helped managing that patient, and up to 5 references. And this QR code leads you to JSCAI formatting guidelines for more details about it. So we kicked off this section in January this year. So this is a great opportunity for fellows, and that's how we came up with the first paper. This is one of my imaging fellows at Yale, and we submitted a paper on the management of recurrent in-stent calcium reprotrusion. So there is calcified nodule that is stented, and it keeps coming back multiple times, and then we put together this scenario where we have multiple procedures done, one with IVUS, the other one with OCT, where we're not discussing much about atherectomy devices and stuff, but really on how you interpret imaging, how you diagnose that, how you use the imaging information to guide your management. So that was the focus of this paper. We also ask authors to be well thought about the images they are going to make. So in the journal, we get many case reports or submissions where we have like one IVUS cross-section and then a long text trying to explain what these IVUS cross-section tries to show. So we want authors to consider images to tell a story. They should really tell a story. Representative images should be presented. Key findings should be annotated with minimal overlay on the findings, so minimal text, minimal symbols. The figures should speak by themselves. And we highly request the authors co-register images with angiography. At the end of the day, we want to correlate the intravascular imaging findings with the angiographic findings. We are still relying our eyes on the angiography to put stents in. And present quantitative metrics whenever meaningful, right? So key metrics are really important, and that's also how we teach physicians and fellows on what is important to measure and how you do it. So that's a great venue to also explain those things. And the legend should just describe this story that we're just telling. We're asking authors to submit online videos. And for example, we want continuous sections of the video. I'm just finishing here. And when you have like multiple videos, try to work a little bit and do something as we did for the first paper. Just combine them all and be creative. Try to tell a story with your images and your videos. And we're planning also to have a webinar where the 3 editors are going to discuss findings and really discuss the topics of intravascular imaging and physiology with the first author or the fellow who published. And I hope that we can get you and your fellows submitting imaging and physiology cases to our JSCAI section. Thank you so much.